Welcome everyone, and thank you for joining us for this session on one of the most challenging topics in contemporary atrial fibrillation management, persistent AF ablation in the era of PFA. While PVA isolation remains the cornerstone of AF ablation, outcomes in persistent AF contribute to drive the search for more effective adjunctive strategies. The key question today is how best to address the atrial substrate VOM PBI in order to improve long-term results. We are delighted to welcome two leading experts in the field of cardiac electrophysiology. First, Dr. Grégoire Massoullie, cardiac electrophysiologist at the University Hospital of Clermont-Ferrand in France, who will discuss the anatomical vein of Marshall approach and the role of VOM intervention as an adjunctive strategy for persistent AF ablation. And then Professor Amir Jadidi, head of Arrhythmia and cardiac electrophysiology at Lucerne Cantonal Hospital in Switzerland, will present a tailored substrate-based approach focusing on individualized identification and treatment of arrhythmogenic atrial substrate. Together, they will explore two different but potentially complementary strategies aimed at improving outcomes in persistent AF and help us better understand how these approaches may fit into our evolving treatment algorithms in the PFA era. So let's hear with Dr. Massoullie.
Thank you. Thank you for this introduction. And thank you for the invitation today and organizing this controversy. So, as you said, we are living through a very important technological shift, especially with the emergence of pulsed field ablation. And still, one question remains: in persistent atrial fibrillation, what should we do beyond pulmonary vein? In which patient and when should we do it? Currently, two philosophies can be discussed. The first is signal-based or signal-guided approach, which could be described as a patient-tailored or substrate-based, relying on identification of electrical abnormalities such as dispersion, fractionation, specific electrocardiogram patterns. And this approach belongs to a very long history from the early concept of atrial electrocardiogram fractionation that was implemented into the stepwise procedure to more recent ARM-assisted mapping strategies. But at the end, the goal is to identify and neutralize a patient-specific substrate. On the other hand, the second philosophy is the anatomical approach. It does not primarily aim to chase every abnormal electrogram. It's a combination of a lesion set with pulmonary vein isolation and an organized lesion set, usually a roof line or dome line, a mitral isthmus block with the help of ethanol infusion into the Marshall vein, and for some patients, CTI block. The main goal is to structure the atrial conduction and prevent anatomical macro-reentry. This approach, which I find very attractive and also I'm using it in my daily practice, is partly inspired by the Cox-Maze logic. The surgical Cox-Maze procedure was designed to maintain sinus rhythm by compartmentalizing the atria while preserving organized atrial activation as much as possible. I mean, sinus rhythm has to be as sinus rhythm activation has to remain as physiological as possible. And the Marshall plan attempts to reproduce part of that logic into the left atria using catheter ablation. One important point is that the lesion set has been designed to preserve physiological atrial activation, sinus rhythm as much as possible. Look at where at the line are performed. They are positioned in relation to the physiological collision zone in sinus rhythm and do not create arbitrary conduction barrier inside the left atrium. One of the central key components of the anatomical approach is a mitral line and to achieve a mitral isthmus block. It has been 20 years that we are performing this kind of line, especially if you perform substrate ablation. Some patients are coming back into your lab with recurrence in organized atrial tachycardia, and for 50% of them, the mitral isthmus is involved. And if you look at this beautiful publication from the Bordeaux group, from Agathe Delbove, that are CT scan from the mitral isthmus, you clearly understand how complex this region is. It's not only an endocardial line, an endocardial muscle bundle between pulmonary vein and mitral isthmus. It's involving fat, vessels, coronary sinus, the great cardiac vein, the Marshall complex, and all this complexity explain why mitral isthmus block has been difficult to achieve, difficult to validate. And this is where ethanol infusion of the vein of Marshall is particularly relevant. In all series, using radiofrequency and ethanol vein of Marshall infusion help us to achieve in 92 to 93% of cases an acute block. And even if the durability of the block has not been clearly evaluated and occurred, it's clearly helping to achieve durable block on the mitral isthmus. And vein of Marshall infusion, ethanol infusion, is not only a matter of mitral isthmus block. The Marshall is potentially an arrhythmogenic structure. It could be involved in localized reentry, autonomic modulation, atrial fibrillation triggering, and data are supporting this concept. If you look at the venous trial, adding vein of Marshall ethanol infusion to PVR improves sinus rhythm maintenance, and outcomes were even better when the lesion set was complete, especially when block were effectively achieved. And these results have been confirmed in the more recently randomized clinical trial of the Marshall plan. For the moment, we only have the description of the single center results from the Marshall plan randomized clinical trial. But the prompt AEF published 2 years ago is also very encouraging, showing out that sinus rhythm maintenance is better when you are performing an anatomical approach compared to PVI alone. That being said, even if there is clinical results, and I find the Marshall plan an elegant approach for atrial fibrillation, I must acknowledge that it's not free. I mean, you must master a technique. You must learn how to cannulate the coronary sinus, identify and cannulate the vein of Marshall using angiographic catheter. You also must be able to understand the variable venous anatomy of the atria. And those are only parts of the procedure. Because at the end, you must validate your line and your block, both endocardially and epicardially. And of course, this is adding some time to your procedure. The procedure duration compared with control strategy are longer in the randomized control trial, approximately 25 to 45 minutes more compared to PVI. In my personal experience, that is very long. With an optimized workflow, a trained team, regular practice, I think you can reduce this duration by a factor of 3 to 4. But it's asking to perform not on a daily basis, but frequently the Marshall plan. And then I fully understand that the learning curve at the beginning, when you are implementing Marshall plan into your lab may represent a significant barrier to implementation, especially given the fact that if you are performing a signal-based ablation, you are using the same mapping catheter, the same ablation catheter, and that approach do not require to master a new technique to achieve mitral isthmus block. A second limitation currently is with the emergence of PFA. I think we should be cautious about PFA and anatomical approach. The second limitation for the moment is might be the emergence of PFA. I think we should be cautious about PFA and anatomical approach. Of course, PFA has made PVI and posterior wall ablation technically easier with very encouraging results. But regarding the mitral line, especially with one-shot catheter, the rate of acute block can be very impressive. And I've experienced it myself. It's quite easy to obtain mitral isthmus block or eventually to stop a perimitral flutter. But durability of the block seems very, very low in the first published registry. And even with focal PFA catheter, recent data, a case report suggests that non-sustained mitral isthmus block may require vein of Marshall ethanol infusion to obtain a durable mitral isthmus block. So I don't think for the moment that PFA could be an answer to this anatomical approach. Another important point is that looking at the result of the substrate ablation is the other side of the coin. The substrate-based approach, an example in tailored AF, a very important trial, very interesting, that teaches if you target a patient-specific electrical substrate, first you can identify it, then treat it, and you obtain a clear reduction in atrial fibrillation recurrence. I'm not here to discuss the pathophysiological rationale of this approach. It's clearly providing evidence that in some patients, persistent atrial fibrillation is maintained by electrical substrate, what we could call eventually drivers, micro-reentry, fibrosis, but those can be mapped, ablated, and reduce the atrial fibrillation burden. But if you look at the recurrence of any atrial arrhythmia, you can clearly see that the results are less optimistic. And patients had recurrences, mainly atrial tachycardia, and they often, this atrial tachycardia, use anatomical isthmus. There are parametral circuit, roof-dependent circuit, eventually CTI, and even with a signal-based approach, anatomy often comes back into the discussion through organized attack, as it is the case in tailored AF. Regarding the anatomical approach, in our experience, this will be this paper has been accepted this month in the JACC EP. After an anatomical strategy, 2/3 of the patients with a recurrence will recur in atrial fibrillation despite a complete and durable anatomical lesion set in 50% of cases. In this patient, in atrial fibrillation with mitral line block, roof line block, PV isolated, I'm clearly questioning myself that what should I do? Perform additional substrate ablation, maybe better select patient, or a more comprehensive risk factor management? That's not clear for me. What should I do now? And finally, my last thought would be about the treatment sequencing. Some patients will remain in sinus rhythm after PVI alone, and substrate-based approach or anatomical approach might not be necessary. And it's not clear for me which patient should receive ablation beyond PVI during the first procedure. Should we just perform it in redo procedure? And in case of redo, should we prioritize an anatomical strategy or a substrate strategy? So to conclude for today, as I said in my current practice, if I need to go beyond PVI, I favor an anatomical approach because I think it's efficient, it's safe, and provide a reproducible framework because it addresses non-anatomical corridors of atrial tachycardia, and it's also preserving physiological activation in sinus rhythm. I'm not here to dismiss signal-guided ablation. It is also not to claim that anatomical approach should be systematically applied to every patient with persistent atrial fibrillation. But in the future, will probably be not as binary as the discussion we have today between anatomical ablation and signal-guided ablation, but maybe a question of choosing the right strategy to the right patient and probably at the right time. That's what I wanted to say to you today. Thank you for listening.
Okay. Thank you very much, Grégoire. We will continue with Amir Jadidi, and then after both presentation, we will discuss some questions. So, Amir?
I'm going to talk about catheter ablation of persistent atrial fibrillation in the PFA era, and especially focusing on novel sinus rhythm-based substrate-based ablation. So historically, the STAR-AF2 study prove that there is no difference in doing PVI only versus additional linear lesions or cafe ablation during atrial fibrillation using the NAVIX algorithm, CFE mean. And all three methods were about 50 to 60% success rate at 18 months follow-up. However, this study is dating from 2015 and the methods used were different. Point-by-point ablation was not guided by ablation index and no lesion interlesion distance was measured. Newer studies using interlesion distance and ablation index show that persistent AF patients who are younger and just have a little LA dilation without low voltage or slow conduction substrate as mappable during sinus rhythm, they have quite very high success rates and respond well to PVI only. As you can see in this study published in JACC EP in 2022 from Chinese group, we can see even 85% success rate in this younger group of patients with persistent AF without low voltage substrate in sinus rhythm at 18 months follow-up. In contrast, in the same cohort, those patients with persistent AF who did present some little areas of low voltage substrate and slow conduction sites, they responded less to a PVI only approach, had a success rate at 18 months of 60%. So we have to deal with a wide range of different extent of remodeling processes in the left atrium in patients with persistent AF. So if we look at the paroxysmal AF patients, the PV triggers are the main issue. The atrium is not yet so much remodeled. Atrium is a little bit dilated, not so much. The main arrhythmogenic sites are lying within the PVs, and PVI works very well in this patient group with 90-95% success rate. Persistent AF, however, we have different kind of remodeling. So we have younger patients and age below 65 to 70 years who mainly have LA dilation. And on mapping during sinus rhythm, we very rarely see areas of low voltage and fractionation during sinus rhythm. And in older patients, however, we can observe not only dilation, but in increasing areas of low voltage, slow conduction, fractionation, late potentials. And these patients respond less well to PVI only. So I think more and more data from different studies are showing that we are dealing with different stages of disease where different triggers and mechanisms are responsible for arrhythmogenesis. So previously, the Bordeaux group and our group were able to show that areas of special temporal dispersion during atrial fibrillation were responsible for localized reentries and rapid activities during atrial fibrillation. And we were able to show by double mapping and cardioversion studies, so mapping patients during atrial fibrillation and then mapping them again during sinus rhythm, that these areas correspond well to fractionation and late potentials during sinus rhythm, which lie within low voltage areas in sinus rhythm. So that's why in the next step, we were interested to see if an ablation approach targeting slow conduction, low voltage substrate in sinus rhythm might resolve the problem of persistent AF patients. And we conducted the SOLVE-AF trial addressing this question. And here an example of what was being assessed in this multicentric randomized prospective study, which was presented at the ERA in Paris in 2026. So we can see the patient with a presence of atrial low voltage and slow conduction substrate during sinus rhythm in the left atrium on the posterior wall on the roof. You can see this patient might be ablated with a PVI only or additional ablation of these low voltage, slow conduction areas to isolate them from the remaining high voltage, better conducting and better contractile areas of the atrium. And you can see on the right side in the slide, the kind of electrocoms that were targeted for ablation and were tagged with blue and yellow points. So yellow points are showing basically late potentials, isolated late potentials, whereas the blue points are showing fragmented, prolonged potentials during sinus rhythm, meaning corresponding more to more slow conduction events and more reentry areas. And here's the flow chart of the study. So initially 261 patients were screened. Finally, a total of 231 patients were included in the study and underwent follow-up with 7-day holter at 3, 6, and 12 months post-procedure. So as you can see, all patients underwent initially cardioversion and then underwent high-density left atrial voltage and activation mapping during sinus rhythm. And more than half of the patients did not present low voltage areas in the left atrium during sinus rhythm. So 134 patients were in the registry group, had no low voltage substrate, no fractionation in sinus rhythm. They underwent a PVI only. Based on point-by-point contact force and ablation index guided with attention to interlesion distance below 5 millimeters. So this group, 123 patients, finished completed follow-up. And a total of 114 patients were randomized to PVI only versus PVI plus additional sinus rhythm substrate ablation. These patients had relevant low voltage substrate at 0.5 millivolt threshold during sinus rhythm. We can see the patient, we can see the kind of signals that were targeted that I described already before. Here you can see in yellow points are single lay potentials, isolated lay potentials, whereas blue points on the right side are the prolonged fractionated potentials. Both kind of electrons were tried to be abolished or isolated within the box lesion if there was a large area of low voltage. And the yellow points, if they were not within the PVI lesion set or within the low voltage area of the box, they did not have to be absolutely all ablated, but the blue points had to be ablated. Target of ablation was PVI plus elimination of these fractionated prolonged activities that we consider as slow conduction arrhythmogenic sites. Here the patient characteristics: total 231 patients, 33% females, median age 67, and patients have dilated left atria with a LA volume of 115 Carto. And now if you look at the patients without low voltage substrate, 123 patients, the second column, we can see that 82% were male and the mean age was 63, whereas in contrast, patients with low voltage area, so if you look at the third column, you can see those patients presenting low voltage were older, in median 71 years old, and we were in 55% female. So more female patients present more often than male patients low voltage substrate, and the patients with low voltage presence are older. So next slide, please. Here we can focus in the pink boxes on the low voltage patients. So those who were randomized to PVI only versus PVI plus substrate ablation in sinus rhythm. We can see that the subgroups of low voltage patients are homogeneous. So the percentage of females is similar with 25 to 29% in those subgroups. The age is similar with 78 years, and LA diameter is about 45 millimeters in echo, and the LA volume is non-significant different. So here we have the results of the PVI only versus PVI plus sinus rhythm substrate ablation. If you look at the patients in the registry group, these are the persistent AF patients who do not present any low voltage or slow conduction in sinus rhythm. This is the blue curve. So PVI only in patients without low voltage substrate in sinus rhythm is working quite well. These patients respond in 76.8% well. They preserve the sinus rhythm after 1 year, after a single procedure. And now if you look at the patients who do present low voltage substrate and who underwent a PVI only, this is the red curve. You can see that the success rate, sinus rhythm maintenance rate is lower in this group of patients with substrate. It's about 59%. And if In this group of patients with low voltage substrate, we do additional ablation of these low conduction areas, these kind of potentials that I showed you before. We can increase the success rate to the range of the patients who don't have any substrate. So like also 77% after 1 year. And very interestingly, we can see now the AF freedom rate is very high after the substrate-based ablation in sinus rhythm. So a PVI plus substrate-based ablation in sinus rhythm, the yellow line, gives you AF freedom rate of 89% at 1 year after a single procedure, which is in the same range as the patients who do not have any low voltage substrates, low conduction substrate in sinus rhythm, and undergo a PVI only. They also have a AF freedom rate of 84%. The rate of flutter and atrial tachycardias after this kind of ablation, targeted ablation of the slow conduction sites in sinus rhythm, is not higher than after a PVI only approach. I would like to conclude the results of the SOLVE-AF study. Persistent AF patients without relevant low voltage substrate were younger than those with low voltage substrate, 63 versus 71 years old, were more frequently male, 80% versus 50%. Arrhythmia freedom rate at 1 year was significantly lower in patients with relevant low voltage substrate who underwent circumferential PVI only compared to those without low voltage substrate undergoing CPVI, 59% versus 77% success rates. And patients with relevant low voltage substrate undergoing CPVI plus had improved arrhythmia freedom rates at 1 year. So CPVI plus substrate ablation in sinus rhythm versus CPVI only, and the success rate were 76% versus 59%. And 12 months AF recurrence rates were 10.7% versus 33% and 16% in CPVI plus substrate ablation versus CPVI only versus registry. In summary, sinus rhythm maintenance after CPVI only is significantly reduced in persistent patients with relevant low voltage substrate compared to those without. CPVI plus additional ablation of low voltage areas below 0.5 millivolt and abnormal electrograms during sinus rhythm completely restores arrhythmia freedom rates in patients with relevant low voltage substrate. And now we can answer the question how to treat which patient. So we can see paroxysmal AF patients and younger patients with persistent AF patients who have LA dilation without low voltage local action areas, they respond well to PVI only. Paroxysmal AF patients, 85 to 90% success. PVI only in persistent AF patients who are younger, don't present low voltage substrate, 75% success rates. And this is with point-by-point RF lesions. So if we use in these patients current technology of PFA, the PVI success rate in these patients will be even higher than 75%, will be about 80%, because the PVI job will be better done. And in contrast, the patients with advanced stage of atrial remodeling, dilation and fibrotic remodeling, low voltage and slow conduction areas in sinus rhythm, these patients do not respond very well to PVI only, 55 to 60% sinus rhythm rate at 1 year. And if you do treat the sinus rhythm slow conduction substrate, you can increase this after a single procedure to 75%, still using the point-by-point approach. So these are the centers who participated to the study. And currently using PFA-based approach, if the patient has an intensive substrate, we just ablate the substrate, and we don't go for areas of high voltage where the contractility is preserved and where the conduction is needed to nourish, to activate the left atrial appendage. So in this case, for example, this is a patient very advanced disease. LA is dilated. We have low voltage substrate and slow conduction sites on the anterior septum that you can see on the right side of the image. And we have also some kind of low voltage at the roof on the posterior wall. So this patient underwent PVI with a FARA-wave that you can see in the cardio as a circle. And also the roof area, which was low voltage and presented some slow conduction areas, was treated with a FARA-wave catheter. And in contrast, in the anterior wall, we treated the low voltage areas, which are quite strong low voltage. You can look at the red areas, they are very in sinus rhythm below 0.25 millivolts. So it's easy to block this line. If you do ablation line interlesion distance below 5 millimeter with ablation index of 530, 50 watts or 45 watts, you will block 80 to 90% of the lines. Yeah, as I told you, the PVI job is better with a new technology of pulse field ablation. As you can see, we have here the success rates at our center in 447 PFA, first two PVI cases, 39% were persistent AF patients, all patients underwent a PVI only with far wave, and you can see on the right side of the image in 12 months follow-up, success rate in paroxysmal AF is 92%, in persistent AF is 84%. Those who had recurrences were remapped, and nearly all of them have low voltage substrate, or they have an anatomical lesion why PVI did not work, because veins were too big and the flow catheter was moving inside the veins, so the veins were not well isolated. I would like to conclude. PVI using the pentaspline PFA catheter results in high 12-month arrhythmia freedom rates, both in persistent and paroxysmal AF and persistent AF. Younger patients with persistent AF who do not have low voltage substrate, especially patients with recurrences after PVI using the pentaspline PFA catheter presented persistent AF with advanced left atrial remodeling on 3D substrate mapping in sinus rhythm. They presented dilation and relevant low voltage slow conduction substrate in sinus rhythm. An additional substrate-based ablation in this cohort improves success rates of catheter ablation for persistent AF. So thank you. And I hope I could answer some of the questions that my predecessor said, because he said in future we will look which patient needs what. I think we can already say which patient needs what. The patients, irrespective of the type of AF, persistent or paroxysmal AF, if they don't have slow conduction slides, low voltage areas in sinus rhythm, the mapping should not be done in AF, because in AF you have some functional collisions and we cannot very well interpret what is happening in this condition. But in sinus rhythm, it's very reproducible and everybody understands. We have a lot of experience with that from other arrhythmias, from VT mapping and VT ablation. We know how to interpret the signals. We know what is the slow conduction. And this is exactly the same mechanisms in persistent AF. And SOLVE-AF is not the first and the only study showing these results. We have now 5 studies in total with a similar approach in sinus rhythm, low voltage guided ablation, showing positive results if this is done. So I don't know what you think about this approach. We can also combine it with event commercial, of course.
It's very two approaches are very different, but both approach have very good results. So my first question is for you, Amir. One of your last slides was on the left atrial flutter after PVI plus ablation. And my question was, if you make a lot of ablation in late potential in the posterior wall, for example, do you assure to close, to complete the line, the roof line, to avoid left atrial flutter on the roof, or do you just ablate the late potential without blocking the line?
No, if your lesion is big and the remaining tissue is very narrow, then you will have a high chance for recurrence of atrial flutter. So if you have a wide area of low voltage, like in the cases I showed, both cases, the first with RF ablation where the posterior box was done, the last one with a far wave catheter where the low voltage areas were targeted. And because there were also some fractionated areas which were not marked on this map, unfortunately. And so once you start to treat this, you have to treat it all. And anyway, the whole atrium the whole posterior wall was diseased in both cases. So if the whole posterior wall is diseased and you have slow conduction, you have to take away all of that. Otherwise, you will have localized rent. If you leave some of them there and you don't treat them, you have a chance of also localized re-entries or macro re-entries if the line is not blocked. But anyway, as we are targeting low voltage, slow conduction tissue, and it is all over the posterior wall in the two cases I showed, in both cases you had to do it completely. But of course, you're right. If you have a small area of confined area of slow conduction, then we try to attach it to the PVI lesion, if possible, to the one with the other side. Or if it's in the middle of the atrium, then you have to decide. Either you leave it because it's not ill enough, because it's just a spot. You say, okay, we give a chance. We just keep it like this. Or if it's very wide, diffuse disease, then you need to do it completely. And look also that you block the line or the posterior wall. If you use far away, this is, and if you're targeting low voltage tissue, it's not difficult to block it.
Thank you. So in cases of very sick left atria, both approaches are common because you have to complete the line when you ablate a lot because the left atria is very sick. So at a certain point there is both approach are joined because you can't avoid to do line when you make a lot of substrate in very sick atria. And I have another question for Grégoire concerning the pure anatomical approach. You mentioned a case report which needed a vein of Marshall alcoholization, even with the use of focal PFA catheter. And I would like to ask you your advice because there is a lot of new tools and probably some focal catheter able to have lesion even with the fat tissue. And don't you think that perhaps in the future focal PFA will have a very good efficacy?
There is a lot to say about PFA catheter. First, the lesion strongly depends on the type of catheter we are using, the anatomy, and also the tissue heterogeneity and the way the pulse distribute for each lesion. The mitral isthmus is a very nice example of where PFA may struggle. The heterogeneity of the mitral isthmus, where there is layer of fat, layer of muscle, is also an electrical barrier to the electrical propagation, as it is for the thermal lesion. So I think for the moment, the PFA catheter, even if they are able to addresses more epicardial structure, that they are at some point they will struggle to achieve epicardial block in this specific area. It's not a matter. It's not depending on the energy we are using. It's depending on the way it can reach epicardial protected structures. So for the moment, even if the acute success is very impressive, and I think we do not have a clear protocol, even with the latest focal catheter, to achieve durable mitral isthmus block. And we need data to clearly know if we can get rid of the vein of Marshall ethanol infusion thanks to focal PFA catheter or not. And for the moment, from what I see from the last case report or from daily practice, I think we still not have found a solution using only PFA.
Yes, of course. And I have another question to try to join both approach. What do you do in case of redo case with a very good first procedure with all the line are blocked, and then the patient had AF recurrence, persistent with the left atria is not too much dilated. So you take him at the EP hour. What do you propose to these patients?
It's a, this is almost a weekly question. The first question I ask is, should I redisconnect vein? And if they are disconnected, finally, once you get inside the left atria, the second question is, should I perform ablation again for this patient? Because usually when patient came back in atrial fibrillation, it means there is something quite evolved inside the left atria, a very severe cardiomyopathy. I'm very interested into the SOLVE-AF result because it's also telling me the outside vein substrate can be targeted as interior AF, and we can obtain from a better sinus rhythm maintenance on the long term. But given the fact that most of my patients already had a complete anatomical lesion set, I'm always wondering, maybe at some point I shouldn't have performed atrial fibrillation ablation in the first place. And how can I decide that? Because looking at the guidelines and my daily practice, I do not have enough tool to identify them, except when they have very enlarged left atria, which is sometimes a bit misleading.
Yes,
So,
thank you.
in short, substrates is an option or nothing, depending on the severity of the disease.
Thank you. And Amir, what do you think about redo procedure in your case?
So, I think the SOLVE-AF is an interesting trial because it really reflects also our experience in the last 10 years. I first started ablating in the AFib. Stepwise, then I tried to do this confined to the low voltage areas and confining this more to the areas with rapid activity with high consistency of repetitive cycle length coverage. And then we saw that all of this is still not 100%. You still have are ablating still some bystander tissue. And then if you look at the patients in sinus rhythm, you can see many of those patients who you thought they have something, in sinus rhythm, they have nothing. And then if you just look at the sinus rhythm, you will see if you treat them, and just I show you two examples, the SOLVE and the study Stable Sinus Rhythm 2 by the Chinese group. If the patients with persistent AF, they have no low voltage in sinus rhythm, they respond very well to PVI only. You don't need to do Marshall or anything else. Yeah, you have 80% success rate in those patients. And those who come back because you don't achieve this PVI, it's because maybe the PVI was not perfect, because the healing was not perfect. Maybe there is something else, or maybe they have a SVC trigger, or maybe they have a vein of Marshall trigger. Then you have to look for it. Then you have to go beyond the PVI only if the PVs are good at the first time, after the first time. So, but the data are very clear, and I'm convinced, completely convinced, not only from our own study, but there are many other studies showing the same. So I'm convinced you may do beyond PVI, and I am convinced, of course, from my approach. But if you are convinced from your approach because you have a good experience with it, you may do this, okay? But then I really you should consider this really when the patient does not respond to PVI, not at the first time. Or you know that the atrium is very diseased, so this patient will not respond to the PVI only, and this patient really needs more than the PVI only because he has only a success rate of 30–40% if the atrium is completely diseased. In that case, we can see this already. There are some non-invasive markers. Of course, you can map, but if you're going for non-mapping approach, single PVI, you don't have a mapping system maybe. So in that case, you should look at the sinus rhythm P wave. If you amplify the P wave, you can see the duration of the P wave is longer than 160. You have a Bachmann block pattern, then you have a diseased atrium. Then you need to do more because in these patients do not respond well to PVI only. We can also look at the echo strain also reflects the LA, the state of the left atrium. Of course, you need to have the P wave from the sinus rhythm in 12 lead, or you need to have the echo strain from sinus rhythm echo. So you need to cardioverse the patient prior to the ablation procedure and to decide. But there are also some indirect markers for atrial cardiomyopathy. As I said, and older patients may have atrial cardiomyopathy. The younger patients nearly never have. So if you have a patient who's younger than 65 and he has not had mitral valve repair or some special disease of the atrium, then he doesn't have low voltage substrate. He's just obese, and he has a HFpEF, and he has just dilation. It's a stage of dilation, high pressure, and in these patients who do a good PVI job, you will have up to 80% success rate. These are many different studies showing the same. So I think it's important that we don't harm the atria at the first to decide who really needs more than PVI, and the data are already there to show us that the younger patients do not have more disease. They don't need more at the first time. If it doesn't respond the second time, you can map, you can go for more, of course. And we preserve more contractile function of the atria. This is important for the patients, I think. I don't know what you think about that.
Do you have compared the P wave in sinus rhythm for these patients to make a comparison with your success rate?
We will do this. This is a secondary analysis. We will do this. Yeah, because we have the data from the registry group who had no low voltage substrate, who underwent PVI only, with quite good results, 76% success at 1 year. And then we have both subgroups of low voltage patients presenting substrate, in which one group had PVI only with high recurrences, and both AFib recurrences. 1/3 had AFib recurrences, and another 20% had ATAC recurrences, or 15%. And the group of low voltage patients who underwent additional substrate ablation with better results. We can look what is the P wave characteristics and what is the predictor. We will look at this, and we will try to publish this, and I think these are interesting things. But we already have all of this data. We have access. We all have access to this data. The P wave is the clue, and the strain probably also, LA strain during sinus rhythm. Both non-invasive markers tell us the stage of the atria, and they also tell us a lot about the risk for subsequent stroke. Because if the atrium is full of fibrosis and the contractility is not there, even in sinus rhythm, the patient will still be at risk. And in these patients, we should not stop anticoagulation. And if you look at the two positive studies, Alone AF and the other one from Atul Verma, what was the name? It was published beginning of 26. So both of them analyzed the mean Charles-Watt score was about 2 to 2.5, and the LA were not dilated. 1/3 of patients were only persistent AF patients. So these were low-risk patients. If in low-risk patients you achieve sinus rhythm maintenance, so these patients don't have low-voltage substrate. They didn't have a history of stroke. In these patients, you can stop on long-term anticoagulation. But if your atrium is very diseased, that's why we have to pay attention to what we are doing. We don't have to ablate too much because we are killing atrial tissue and reducing the contractility, which is important for the prognosis of the patients.
Quick question. Don't you think you are selecting that way a subgroup of patients with a more severe atrial fibrillation phenotype, given the fact that 70 years old is the mean age, left atria seem quite enlarged, and would you consider that for most of the patients you may try PVI first and then wait for recurrences, or in your daily practice you already say to this patient, I want to do something beyond PVI, because it will have an impact on how you organize your cath lab and you prioritize your procedure. Since we get PFA into our lab, it has a bit changed the way we are performing PVI. especially given the fact that it is a reproducible procedure with a mean duration quite similar in between patients, as we are not mapping the whole atria and performing an anatomical ablation. So from your point of view, how do you organize your cath lab and your patient selection?
Yeah, I think the data are very clear. So all of the persistent paroxysmal AF patients, just PVI only, single shot, we don't do mapping. In young persistent patients, similar situation. You can say, okay, we know the young persistent patient, he doesn't have low voltage substrate. He will respond well to the PVI. And I showed you even our own data with a single shot device, pentaspline catheter. They are very good in the persistent AF cases at 12 months. We have 84% success rate. We are our own really surprised and positively surprised that the success rate is as high as that. And of course, they don't have a reveal. They don't have 24 hours ECG monitoring. They have been seen at 3, 6, and 12 months with 3-day holters. And they come back if they feel themselves arrhythmia. But this is the clinical routine follow-up. And this is the level of success rate that we can report with this kind of follow-up. And then now to say, okay, which patient should we go for mapping? And then, of course, if you know that the high-risk patients for recurrence, where PVI doesn't work, are the patients older than 68, 70 years. And we know also that we can look at the P-wave. So we try always to look at the P-wave. If you see the P-wave is very prolonged, more than 160, 170, then I know PVI only 20 to 30% success rate at 1 year. So the patient will come back with atrial flutter and et cetera, et cetera. It's like you're going for an incomplete treatment in this patient. You know it already beforehand. But if the P-wave is not very long, so we look at the P-wave and the P-wave morphology. If the P-wave is less than 150, 155, then you can choose a non-mapping procedure. And if you think the patient might have some anatomical anomalies, big PVs, big atria, then maybe you also want to be sure that you're doing a good PVI job. Just for that, maybe we also take 3D guidance to be sure that we are doing a good antral PVI job. Otherwise, you will have recurrence because the PVs are not well isolated. We are not antrally isolated, but segmentally isolated. That's what we do here.
I was looking at the mitral plan result, especially to the volume of the left atria. The mean volume was around 180 millimeter, 190 millimeter. I think it is not exactly the same left atrial volume you get in your less sick persistent atrial fibrillation group, with probably shorter atrial fibrillation duration, as you said, younger age and beautiful P-wave. Considering the patient in which you are performing substrate ablation, I can see that you are performing anterior line or something similar, but it's quite difficult to obtain an anterior line block. And I'm wondering, with this anterior obstacle, do you sometimes have to perform mitral isthmus block or to complete the anterior line block, or do you struggle with, for example, biatrial flutter, which are, from my experience, more frequent in this case?
We don't have this at all because we only do the line if the voltage in sinus rhythm is below 0.5 in sinus rhythm. So if the voltage at some points and some areas in the septum is if the low voltage area is not continuously below 0.5, we have some spots of intermediate voltage below 0.5 and 1.0, we don't do the line because we know that we will not block this line. So we only do the line if the low voltage area in sinus rhythm is below 0.5, mapping them with pentarray or octarray, so with small electrode mapping catheter. We have a lot of experience with this approach, and as I told you, the success rate of the linear block in this situation, when you have a low voltage area already below 0.5, then the success rate is very high. So if the patient, even if there is a recurrence, then you do the same line again, and then you will block it after the second time. He will not come back again. It's not so complicated anymore to block these lines. With RF, we use SDSF catheter or QDOT, and we use 50 watts, ablation index 540, contact force 12 to 15, and interlesion distance below 5. Yeah. And only the line is only done is the whole area continuously is below 0.5. If you have intermittent areas of 0.7, 0.8, we know we will not block this line. So we don't start, because if you start a line where you know you will not block, and it's clear the patient will come back for 100%. So you're giving him no chance not to come back. That's why we only start the line and then what we do in those cases, if they have diffuse, not everywhere below 0.5, we just do focal area ablation where the potentials are very prolonged, the kind of blue potentials I showed. So really prolonged activity, and with this, we get the results I show you. And I think, it's very important. So if the low voltage artery is in front, is anteroseptal, and the atrium is mainly activated via the inferior and lateral LA, where we have the thickest tissue, which gets low voltage very late, blast. I think we should not do the lateral mitral line. So I have left this approach. I don't do this anymore since 10 years now. We do only where there is low voltage, like in the ventricle. In the ventricle, you will never do a line where there is no low voltage, where there is no fractionation in sinus rhythm. It's just the same as in the structural BT. It's nothing else. And you will see the same. It would be interesting. I think I'm here now since 4 years. In 4 years, I had a single patient who would have needed the mitral vein of Marshall approach because the patient had perimitral flutter and he had no single low voltage area. He had a huge atrium. This was a HFpEF patient, very adipose patient, and big atrium, probably also thickening and maybe fatty infiltration from epi. And the patient had no low voltage, even at 1.5 threshold. He had no low voltage on the anteroseptum. And this patient did do a lot of perimitral and with fast conduction over the AV node. He didn't want to be AV node ablated. Of course, he is quite young. He's 58 years old. And this patient, the vein of Marshall would be the ideal solution because you are, as you said, you're ablating the latest area. You're not delaying the appendage in this case. But in most other cases where the patients do perimitral or localized reentry because of the substrate which is developing first anteroseptal, you have the slow conduction sites there. If you do the lateral vein of Marshall line, you are delaying the atrium, the appendage even more, I think. That's my opinion. Because the slow conduction area, the natural slow conduction is developing anteroseptal. Even if you block the lateral line, the progression of the natural disease will go on. So the patient will develop maybe localized reentry, then you have to do there something, some ablation at the point, maybe, or the progression the disease just progresses, and then you will have more and more slow conduction to the atrium, and you have blocked the lateral conduction area. This is my conviction that we should not do the lateral wall. But I know we have the two poles. I don't know what you think about that. What is your
I think
because you do a lot of Marshall, maybe you have experience about that.
Yeah. I think you are treating a very small substrate of patient with the low voltage area in the anterior line, and I would be very interested to know the percentage of patient with anterior block you can identify on the P wave at baseline, and I'm also questioning myself this last 10 years how many patients I had in the same case you have. I should review all my voltage map and try to identify a patient you are talking about, the one with low voltage area in the several parts of the left atria. We are performing for as a second option, eventually first option in selected patients, the anatomical approach in vein of Marshall. And there is some subgroup of patients in which when you realize that there is a huge anterior scar, you do not want to isolate the left appendage. And for this patient, I have to review my lesion sets, but these are quite rare among the last 400 procedures. I don't know exactly how, but I think I could count them on my both hands. So that's why I'm wondering if there is a sub-selection of patients with the way you are treating them. And I would be, as I said, very interesting in the result of your P-wave analysis sub-study.
No, we are treating all of the patients, yeah. And so we are not sub-selecting them before, but the ablation strategy may be oriented by the P-wave, yeah. So
Yeah.
So maybe if you do VNF Marshall, so I think I think we should do the beyond PVI only if the substrate is there. Otherwise the PVI only will be a good treatment option for most of the patients.
Understood.
I think so. I don't know what you think.
Thank you. Very interesting.
What's your experience in Grenoble?
We do substrate and anatomical approach together. I never touch the anterior wall of the left atria, even if sometimes it's really we want to do that because we see very fractionated potentials. But because our strategy is still a PVI, posterior wall, and mitral isthmus, when we do mitral isthmus posterior, we don't do anterior because of the less atrial appendage. But I think we both strategies have good results, and it's difficult to know what is the best without a direct comparison of these two strategies, more anatomical or substrate. Perhaps there is something in the middle, or with artificial intelligence, with the P-wave to know which patient need what when we use P-wave. And after that, perhaps some patients need more anatomical approach and other substrate approach. And probably I don't do the anterior wall because I'm afraid because of the left atrial flutter. I hate B atrial flutter. And we know that left atrial flutter have recurrence, and this is the hell for me. So it's why I'm curious to see if you increase the number of patients, and with PFA, Amir, if you compare PVI and substrate, to know if the difference in recurrence in left atrial flutter will not increase on the substrate group. I don't know what you think about that, because we see a slight difference, a little bit more left atrial flutter in the substrate group, but not significant. It was that in SOLVE study.
In the SOLVE study, the rate of atrial flutter, all three groups was about 13%. About 13. One is 11, one is 13, one is 15. It's not significant. And I think it's not high because we really go for the linear ablation if the tissue is already very ill. So the lines we do, 80% we will block them, and they will be durable because it's not difficult to block them in this condition. And if it's not completely low voltage, we just don't start the line, and we only stick to the long prolonged fractionated areas, which are confined to the low voltage also. So we are not ablating without low voltage anyway. So we are not adding some scar tissue, only there where it's already diseased. I think that's why we don't have a lot of pro-arrhythmogenic effect in this case. What I was surprised about is that the rate of AFib recurrence is so low. This means, because if you look the low voltage, the patients with low voltage who underwent PVI only, they have 1/3 of them have AFib recurrence, 1/3. And the patients who underwent PVI plus substrate ablation, only 11% had AFib recurrence. This means because the PVI job was done the same way, the same quality. So the PVI job is the same in both subgroups, but addressing the substrate, we get less AF recurrences by 19%. This is a big difference.
Okay.
This
I
was
think it's
impressive. It
fascinating
proves also that there is
discussion.
some trigger reentries within the substrate, maybe. I don't know what do you get when you do the Wayne of Marshall? Do you get very little recurrence rate of AFib?
In all population, 2/3 of the patients when they have a recurrence came back in atrial fibrillation, and 1/3 was atrial tachycardia, most of them depending on an unblocked line. So usually we start by cardioversion and verifying veins and lines, and then discussing the strategy. So in our experience, the most severe patients are coming back in atrial fibrillation.
Okay. So this has been a fascinating discussion that could probably continue all the night, but I think we need to conclude. And I would like to thank you, Grégoire Massoullie and Amir Jadidi, for your fascinating presentations. And let's see more data and more studies to compare non-inferiority, perhaps between your both approaches in persistent AF in the future. and let's discuss another time.